Good evening, everyone. Welcome to the 31st monthly webinar series with Dr. Imran Lasker. Thank you, everyone, for joining. We will be shortly going into some case reviews on the Collective Minds platform. We have around 12 cases today to go through. They will be in a collection which I'll be sending via a link shortly. All you need to do is just click onto that link. It's a public link, so it will take you straight to the list of cases, and you can simply just follow along with Dr. Imran Lasker as he goes through the cases. There will be a CPD certificate available at the end of this webinar. All you need to do is just fill in a quick feedback form. Once that's submitted, we can generate your CPD forms. Feel free to interact with Dr. Lasker at any point during the webinar. Use the chat box to answer any questions. Dr. Lasker will also ask you what you think of the cases, so please do feel free to interact with the case. And that's it from me. I will hand you over to Dr. Lasker now, and we can begin the webinar.
So hi everyone, I hope everyone is well. My name is Dr. Lasker for those that don't know, and we're going to be going through some hopefully interesting cases in radiology. I'm in sunny, well, it's nighttime now, but it is Dubai at the moment, just on a kind of a mini holiday right now. So I'm feeling a little bit tired from all the running around. So anyway, and from what I understand, there's Arab health going on at the moment. So me being here is completely coincidental, but apparently it's quite busy around here. Okay, so what we're going to do is go through some cases. I am running off one screen today, but I will try and keep an eye on the chat, try and make sure I have an idea about what's going on and what people are asking. Please feel free to interact as much as possible. You do have the link available from what I can see. So yeah, just try and get involved as much as you can, and hopefully we all get to learn something today. So for this one, let's have a look. So this is a CT scan of an adult patient, and it looks like it is. Oh, sorry, I've got loads of windows turning up. It looks like it's a non-contrast CT scan. So at first I thought it could be a CT KUB, but it's not. This is a non-contrast CT scan of an adult patient. And as we kind of scroll through, on first glance, you may feel as though there's not really much going on. It looks kind of boring actually, but now we're going to have to go to the lung windows and have a closer look. And actually, what I might do is just zoom in a bit. Oh, sorry, let's go zoom and just pull this across, and let's scroll and just go all the way up and all the way from the very top, all the way down, all the way down, all the way down, and just try and see if we can find anything grossly abnormal anywhere. And then obviously if you see something, just feel free to just shout it out or put it on the chat function. I think it was around there and there that I did see something. So one of the ways that you can try and make things slightly easier for yourself is to click on mist oblique, and then you can double click here and you've got your MIP function. This is where you kind of make it so you're looking through multiple slices at the same time. I'm not sure how thin these slices are because it looks like it's probably not all that thin because it looks a bit grainy. So maybe they won't work for this particular case, but that's usually what we'd end up doing. So what we're going to do is probably just close that and come back to just the original one. So it might just come in and out again. So what do we think is going on here? So we did see a couple of lesions located in the left upper lobe. And let's just go back to those lesions. I'm going to zoom in a bit into them and just have a look and see what we think. That one there. And we zoom in. So you got one there. So I remember the story for this one is that they had an initial CT scan, and I think they instantly saw these two lesions located in the left upper lobe, and they did a repeat scan, and it came back looking exactly like this. So not much has changed between it, and I think they may have even had another follow-up, and things still didn't change all that much, but they were relatively asymptomatic. But when you look at this, you've got this lesion here, and it's got a very sort of characteristic appearance. And let's see if there was another one. I thought I saw another one somewhere else, or maybe it's further up. There, another one there. So there's a little nodule there, but when you come up to this nodule, it feels like the oblique fissure is slightly tethered towards it, and there's a few tiny little nodules scattered along there. And when you look at that, it looks like there's a central opacity, and then there's a few tiny little opacities around it, and you've also got a bit of ground glass change around it as well. So when you've got the sort of reticular changes along the fissure, and you've got a nodule which has got the sort of hyperdensity and the sort of ground glass change with a few tiny dots around it, that's going to be in keeping with something as a galaxy lesion, because it looks like a little galaxy, like a little Milky Way. When it looks like a Milky Way, then you have to think along the lines of sarcoidosis. And then again, now you think sarcoidosis, you can actually have sort of reticular nodular thickening along the fissures, and that's exactly what we're seeing. But then they could also have enlarged lymph nodes, right? So lymph nodes wise, I don't think, well, there are a few lymph nodes here that are kind of big-ish. The lymph nodes here look kind of like they could be quite big. When you come up to the hilar lymph nodes, they're a bit difficult to see because obviously it's a non-contrast study. But these are just way too sort of spherical when you look at them. They just look a bit sort of cauliflower-like. When they look like cauliflower like that, then you have to be thinking along the lines of perihilar lymphadenopathy. So now you've got perihilar lymphadenopathy, no appearance, no changes to the two lesions. They've kind of got a galaxy appearance and multiple nodules or reticular nodular appearances to the fissure. You have to go along the lines of this being underlying sarcoidosis. Great. So there was no questions on that one. Let's go to the next case. And I'm going to just, because I'm running off one screen, I've got to keep moving different things out of the way. Okay, so let's have a look at this one. What do we think? So this person was a gardener, and they did have an injury a while ago, but now their fingers really not got much better. So what I always do is try and compare abnormal to normal. So I kind of think that that's going to be a normal looking terminal phalanx. That's going to be your middle phalanx. That's going to be your proximal phalanx. And it's this lesion here that looks very, very abnormal. And then we're going to have to zoom in and take a closer look at that. So let's take a closer look. Oops, zoom, and then just pan that across and just take a closer look at this. So then this is where you've got to kind of go down the idea of, okay, I'm not sure what it is, but is it aggressive or non-aggressive? So aggressive versus non-aggressive. Aggressive would be this lesion looks like it's angry, like it's up to something. And a non-aggressive lesion looks like it's just been sitting there for quite a while. Now, one thing you just want to be careful of, there's a nail that's going along there. So that has nothing to do with the lesion. The lesion is sitting right over here. You can see this lesion is causing a bit of expansile appearance to the actual cortex because this one looks very thin like this, and this looks almost like a little ghost, like sitting there, yeah. And so it looks very expanded. It's kind of been pushed outwards like so. You've got some underlying scalloping of the cortex going all the way along like so, and you've got a focal radiolucency, and it's very, very smooth radiolucency all the way around. And the actual finger doesn't look like it's too bad, doesn't look like it's particularly swollen. You can't really say there's any periorbital reaction. So those things would say that this is a non-aggressive lesion. The fact that it's well defined, it's got scalloping of the underlying cortex, but no breach of the cortex, no soft tissue swelling. This would all suggest that this is actually a benign looking lesion, right? Not a benign, not benign, you say a non-aggressive lesion. And because of the history, this must therefore be an implant dermoid. And so essentially what's happened, you've had a penetrating injury that's gone through into the finger and into the bone, and it's essentially planted like a derm cell within there, and then it ends up proliferating, and end up becoming this lesion that's here. And if it gets particularly large, especially in the long bones, then it could end up having a risk of fracture. So they may end up doing curettage and all sorts of things for something like this. If it kind of increased the risk of getting a fracture later on. Okay, good. So let's go to the next case and have a look. So this one is a plain film X-ray, and this person's got long-standing foot pain. So initially you may think to yourself, okay, well, that's just a fracture, isn't it? I don't need to be thinking much more than that. But there's no significant trauma, and it's been going on for quite a while. And so therefore, and they haven't said anything about it yet. They haven't said anything about any trauma. So we have to think about what else this could be. So one of the things I would notice anyway is that the tibia fibula distance is quite large. So you're wondering whether there's some sort of syndesmotic injury here. But when you look at the actual talus, this looks very abnormal. It looks like there's loss of joint space here and some increased joint space here. This looks like, oh, this could be a fracture, but there's also this increased density located between this region over here. Now, when we come across to this area, this more lateral view, you can start to see that it looks like there's a bit of lack of a show part joint or a talar navicular joint. It looks like this is kind of slipped forwards. There's a few bits of debris located here as well. And you can't really see the talus with the navicular articulation so well. It just looks very sort of disorganized, maybe even sort of pushed inwards or something. So when you've got debris, you've got some bit of disorganization, a bit of destruction, you have to start wondering whether this person's got something like diabetes, because therefore this would point to something like a Charcot joint. And essentially that's what it is. And this would essentially get worse if left untreated. And I think on this occasion they did know they were diabetic, but there could be a situation where the patient doesn't even know they're diabetic and they've just ignored it, and the whole situation just gets worse for them. Okay, that was a quick one. We've got some more difficult cases. So the one things I do for those that don't know, I try and keep a real breadth of cases so that I know there are people who are quite senior, some people who are just starting in their radiology journey. Some people are not radiologists at all and they're just interested in scans. I try and make sure that everyone's got something to go through. So we go between plain films. Sometimes we do a bit of MRI. Sometimes I do throw in the odd MSK case because I am an MSK radiologist, but I do a lot of emergency radiology as well. So I don't know what is going on with this case. Hang on. Okay, let's do that. Okay, so this is a CT abdo-pelvis, and this came in on an on-call session. Patient was feeling like they were obstructed, hadn't passed flatus in a while. So let's scroll through. I always try and have a system with all these things. We have a look and see where this person's got contrast at all. So first off, it does look like they've got contrast here and here, but this looks slightly brighter than here. And this is the portal vein system. You can see that's a portal vein and that's the aorta. So when it looks brighter here, you have to think to yourself, therefore, this is not an arterial or aortic phase. This is going to be a portovenous phase. It's a portovenous phase study. Now, the liver, I mean, to me anyway, it looks a little bit like it's a bit um, too hypodense, just looks a bit too black to me. So therefore, I would be concerned this person's got underlying steatosis. Sometimes if you look around segment 4, which is going to be, so you look at the gallbladder and around there is going to be segment 4. You can sometimes get fat sparing around the gallbladder. Not entirely sure why, but I just see that fair bit. Or sometimes you may have areas that have kind of more normal looking liver. But this one looks pretty diffuse, doesn't it? It looks like, yeah, there's not, there looks like there could be just generalized steatosis there. Now, things that can cause pain are going to be the gallbladder. So you have a look at that gallbladder. It looks very, very thin, so not much going on there. Have a look at the pancreas. Pancreas is here. It goes all the way along like so, all the way along like so. Then you've got your adrenal glands and your adrenal glands there. And then you've got your kidneys, which are all sitting here. And they all look pretty good as well. So kidneys look okay. Those can all be sources of pain. We haven't seen anything grossly abnormal. Now, some of you may spot that there's big sort of viscous that's sitting here, which doesn't quite make sense with any sort of solid organ, that therefore it must be bowel. So it must be some sort of distended bowel. We have to try and figure out what bit of bowel this is. So I always start from the rectum and I just follow it up, 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 and just see what happens. Coming up to this area, coming up to this area, and then it just feels like it suddenly gets quite large. And after that, you've got a bit of a fecal fluid level, and then you've got really sort of distended bowel, like here and here and here. And sometimes it's quite good just to be able to get the lung windows, and that helps you sometimes follow things along because it can be difficult. And you can see this opens into here. My mouse has gone this way, and where else does it go? It goes down to here, down to here. Can be a bit difficult to see beyond this. So now what we have is nothing grossly abnormal in the upper abdomen, but we do have underlying steatosis. But we have significant, which is probably not going to be have very much to do with this. The kidneys look okay, the gallbladders look okay, the pancreas looks okay, but we do have a very distended, large bowel, and it looks like it's emanating from the sigmoid colon. But that sigmoid colon looks like it suddenly gets quite thin and then it kind of becomes quite dilated afterwards. The best thing to do in these situations, if I have it, let's see if I've got the thin slices that go coronal. No. Okay, let's see what happens if I do this. Very weird. What happened? Let's go coronal. Not sure what's going on with the images. I think there's some sort of not sure what's going on, but I think we'll still be able to get what we need out of this case. So let's just pull this. So what we can do is look for something called I think it's a whirling sign. So you can see the kind of sigmoid colon coming up this way. You followed up, you followed up, you followed it up, you follow it up, you followed up, and then it twists like this, and then comes out. And if you keep your eyes over this area, you can see how much it twists. So twist that way and twist that way. And then you've got what would be a coffee bean sign, which is here, isn't it? That looks like a coffee bean from Starbucks. There, like that. And so, yeah, this is a really good way to sort of confirm actually that this is an underlying sigmoid volvulus. And at the time, so the other important thing to always say with these sigmoid volvuluses is there's no perforation and no ischemia, because obviously, if something's twisted around like that, you can end up developing an ischemia, and you can also end up developing a perforation of the bowel. But this actually looks like it's just a pure sigmoid volvulus, and so they may need to end up doing a flatus tube to try and deal with that. Okay, let's make sure there was no questions coming in. Nothing coming in so far. Where's my chat function gone? Chat. Okay, fine. So the next case is a an X-ray. What's going on here? Okay. So this looks like a plain film chest X-ray, and now when I look at it, it looks like the immediate abnormality is somewhere around in the right hemithorax. So let's have a look at the left hemithorax. Whirlpool sign. Can you explain the whirlpool sign? Yeah, yeah, sure. I'll go back to it now. So the whirlpool sign is what I was showing you on the coronal views, and it looks like a whirlpool. It just does that. And I just demonstrate it one more time. And that, for me anyway, is a really good way of finding a sigmoid volvulus. So these days, if I'm worried about a sigmoid volvulus, let's say I've got a really big amount of distended large bowel, the first thing I do is go to coronal view and I just scroll through, and then your eyes sort of just end up fixing on the whirling, right? It's a bit like, when you're watching your bathtub um, the water come out of the bathtub, just watching it go down. So let's have a look. Let's get it back and I'll show you again. So, okay, I'm going to really zoom in on the whirl this time. I'm going to keep it right in the middle of the screen so you just can't miss it. So mouse is here. Look at my mouse is here. Mouse is here. Mouse is here. Mouse is still here. Okay, now keep your eyes on it now. I'm going to do it. It's whirling. See that? If you keep your eyes right here, the whole thing kind of whirls around on itself like that. And that's what you can see. That's the whirling. So it's kind of a bit of a twist in the bowel, and it's really best seen on the coronal sign, on coronal views. I hope that answers that question. Okay, so this one, we're looking at the chest X-ray. So I always look at lung APCs. In this particular case, can we mention the closed loop diagnosis in a colon exclusion too? So, um, I mean, I never really use the phrase closed loop very much unless it's two lots. So closed loop would generally be if let's you've got some bowel going straight like this, and then you've got like a obstruction there and an obstruction there, and so the middle bit is like getting really it gets really, I mean, it's a bad situation because it's obstructed from two ends. And what's the thing that you really notice? There's something very sort of, every time I see it, you can almost see sort of engorgement of the mesenteric vessels in that particular area like this. And you've got your bowel here, and it's really, really distended. And you can see like a transition point there, and then another transition point like over here. And that's when I'd say a closed loop obstruction. If it's just occlusion of the colon, like what you see, I just say obstruction. So I say the exact phrase would be there are multiple loops of, there's a significant dilatation of the sigmoid colon secondary to a volvulus, best seen on the coronal views where you can see a whirlpool sign, like a whirl sign. And then that would be pretty much describing. And then I say no perforation, no ischemia at the time of the study. And that usually is like 99% of what we need to know with this particular person. But yeah, I just stay away from the idea of closed loop because that can mean a completely different thing. Hang on, it's not bright enough for me. Here we go. Okay, so now let's have a look at this chest X-ray. And this chest X-ray, you've got this opacity that is located within looks like the right upper lobe. It looks pretty uniform. Doesn't look like I can see any bronchograms anywhere. And then you've kind of got this sort of linear area over here, and then you've got your lung. So you think to yourself, okay, what's going on? Is it consolidation or anything like that? But actually, this is a collapsed upper lobe, and this would be in keeping with a golden S sign. And the golden S sign is pretty pathognomic of a right upper lobe collapse. But then what you can also see is that there's some tenting of the hemidiaphragm here, which also contributes to the idea that this has got some loss of lung volume. And also, when you look at the hilar, that hilar looks a bit down and that hilar looks a bit up. And that's again because you've had a bit significant loss of lung volume located within the upper lobe over here. Lots of reasons can cause this: mucus plugging, lymph nodes, malignancies. So ideally, this person would need to go get a CT scan to have a closer look and see what's going on and what's caused it. Because on this particular X-ray, I think it's going to be very difficult to know exactly what's caused this abnormality in the upper lobe like that. Okay, good. Do we have non-contrast on this one? No. This is, let's just download these images. I remember this case very clearly because it was a very young girl. She'd come in and the query was, I'm losing sense of smell or something like that. And she'd got the CT scan and then the radiologist called me in straight away, like, oh, what should we do? And at the time, I had no idea what this was. But let's have a look and see. So we scroll through, scroll through, scroll through. The CT head looks like as you scroll through, scroll through, scroll through, there was an abnormality located there. It's a very large lesion located, difference between Pankhurst. How can you, so someone's saying, how can you differentiate between diagnosis of Pankhurst tumor, I suppose, I think assume that's mean collapse, or can both exist at the same time? Okay, let's just go back to that case. So the right upper lobe collapse has happened, right? And it's not pathognomic for a pancreas tumor or any tumor at all. It means that there's a collapse for whatever reason. It could be for mucus plugging. So you've got this bronchi and you get some mucus plugging. You could have a big lymph node here that could be causing that, or you could just have a malignancy that's causing that. So loads of reasons. So, but the problem is that at this point, all you know is that you've lost the left upper lobe lung volume. You've got a golden S sign and you're not entirely sure why, which is why you need to get a CT scan because, yeah, on the off chance that this is an underlying malignancy, it needs to be investigated further. But based on this X-ray anyway, unless there's some bony destruction or anything else that would tell you that there's a really big tumor here, I wouldn't go with tumor or anything like that. And also, if you're worried about this being the tumor itself, it's going to be not impossible, but the fact that you've got this very sort of well delineated underlying sort of S, right, golden S ion, this is going to be the fissure that's kind of pulled up, which means that this is going to be a golden S sign. There's going to be a collapsed right upper lobe, but the reason for it is going to be differentiated on a CT scan, in my opinion. There might be someone who's some sort of whiz kid out there that can tell you straight off, but I think I'd be a bit wary of saying I know exactly what's caused it without having a CT scan. Okay, so let's go to this case. Scroll through, scroll through, scroll through, scroll through. Oh yes, and then yeah, so the lady's got this big lesion located within, where is it? Looks like it's in the septum area. There are nasopharynx maybe, kind of poking out this way, causing significant mass effect onto the maxillary sinus. There's a pacification of the maxillary sinus on this side, a pacification of the frontal sinuses as well. There's just a lot going on here. But the thing is, when you look at it, it looks like there's some bowing of the maxillary wall rather than destruction of the maxillary wall. So when that happens, you know, okay, this has been going on for a while. Whatever this is has been there for a long, long time. And then you kind of see it's getting pushed across this way. And again, there's bowing of all the surrounding structures. A very, very, and when you actually look at it, if you were just to sort of take that square and just not really focus on anything else, then you think to yourself, okay, it kind of looks like it could be a bit bony. And now and I know that whenever I show this case, especially for the 2B teaching that I used to do, people start to think, oh, it could be, they will just go with the angio, I can't remember what it's called, like a very sort of vascular lesion located within the nasopharynx. And that seems to be the easiest answer to go for when you've got an abnormality in the nasal region. But actually, this is a focus of fibrous dysplasia, like a really big lesion of fibrous dysplasia. And I don't have it here, but actually, or maybe this is the contrast in our study, but it did actually enhance with contrast. And that actually can happen with a focus of fibrous dysplasia. And even if you did nuclear medicine imaging, it would still shine up really bright because these things are metabolically active. So yeah, this is just a, I've never seen fibrous dysplasia look like this until this day. And it seems to be one of the cases that when I used to do 2B teaching really throw people off. And so that's why I thought it was a good case to bring in today. And that some of the clues are just this scalloping around it. It looks very kind of osseous in appearance. You can almost see like a cortex to it. And then when you actually look at the bone, it looks very ground glass. And for those that don't know what ground glass is, it's that glass you see when you're walking on the beach and it just looks a bit cloudy because it's been weathered by the sea or something. So it looks a little bit weathered, all this stuff over here. If you did that, it looks a bit like ground glass. Okay, so let's go on to the next one. Okay, and let's download these images to have a look. What is this one again? Kind of scroll. Okay, so first, let's go from basic principles. It looks like it's an abdo-pelvis. Yeah, abdo-pelvis, maybe. When you look at this and this, I guess this looks kind of bright in compared to that, but actually almost looks the same. Difficult to really say. The kidneys are very, very bright. So it's either it's the wrong phase or this might be slightly arterial phase image. Difficult to know, but the spleen doesn't look like it's got that tiger pattern either. So may just have to go with a portovenous phase image, right? Okay, so gallbladder looks okay. Pancreas looks okay. The kidneys, if I look at it, looks, yeah, it looks relatively okay. Maybe want to window that a bit. Yeah, they all look okay. Now we have to just try and figure out what's going on there. So let's have a look at the bowels. Back to bowel, 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 going this way, this way, this way. That's the descending colon coming across the transverse colon, transverse colon. Almost lost it there, isn't it? But there you go. Transverse colon, there, there, down, down, down. Yeah, okay. So it all looks okay. The bowel looks okay, doesn't it? But if I put it here, can anyone see if there's something that kind of just stands out? Yeah, that doesn't seem quite right. Okay, let's come up. If we just come up to this level, just have a look for a second there. So if you look at the leg, if you look at that leg, someone said something. Yeah, exactly. There's a very, very swollen right thigh. And when you look at that right thigh, it looks very, very edematous, doesn't it? And you got to try and think, okay, why is that happening? What's happened here? So what you do is kind of come back up. So the whole leg, how's the whole leg? The rest of the legs look okay. I'll have to come back up. And this is probably not the best test for looking for a DVT, but what you can see is you've got the aorta coming down this way and it bifurcates. That looks good. But when you've got the IVC here and it sort of bifurcates just here, you can see this one compared to that. So that vessel, iliac vessel compared to that iliac vessel, it's a completely thrombosed essentially. Exactly right. So someone said it. So there, this is called May-Turner's syndrome, right? And essentially what's happened is that you've got the vessels kind of impinged just at this level and then getting thrombosed. And then you end up getting this really sort of edematous looking leg. And it's almost, I mean, it looks like a different person. If you would just look at this and then look at that, I mean, that's like twice the size of this. And that's because it's something called May-Turner syndrome. So yeah, well done. Someone's picked that up pretty quickly, so that's really good. And I thought it was probably one of the best cases of May-Turner syndrome that I've seen in my years of practice. Okay, so let's go to this one. Just having a look. Okay, let's have a look from the very, very top. So this looks like a CT head. Scrolling down, scrolling down, scrolling down. Okay, so people may have seen it, but there does look like there is a lesion located here. It doesn't look quite right, does it? And should we be concerned? What's going on? Any other lesions anywhere else? Look in the other ventricle, no other lesions. So you can get a few different kinds of lesions located within the lateral ventricles, right? Some ones may go for a choroid papilloma or something like that, but there's no, um, those things would be producing a lot of CSF fluid, but this is not producing, I mean, it doesn't look like as much in the way of hydrocephalus at all. The lateral ventricles look relatively okay. They don't look like they're particularly dilated. But we do have this lesion that has kind of got this peripheral calcification. Looks very, very, very well defined. It does look like it's causing some sort of mass effect onto the surrounding brain parenchyma. But this is where you think to yourself, okay, is it aggressive versus non-aggressive, right? And how do you figure that out? Well, if the way I always try and explain it is that if you've got a tumor that's really aggressive, it's like having a room full of people and then you throw in a massive elephant into that room. And obviously, a massive elephant in a room full of people is going to cause a lot of disruption, probably injure a few people, right? And that's like your idea of an aggressive tumor. But if you've got a room full of people and you put in a baby elephant, it'll probably sit between everyone for a while. And as it gets bigger and bigger, people start shuffling around, shuffling around, shuffling around, and shuffling around. And then there may be a point where the elephant gets so big that people can't shuffle around, but it's had time to figure it out. And so with this one, it's got such a big lesion. Considering how big it is, there's really not much in the way of edema, right? So this can't really be an aggressive lesion. Whatever this is, it's been there for quite a while because it seems to be that the brain parenchyma has kind of accommodated it. It's kind of, yeah, it's just said, all right, well, we just move out the way for you. And you've also got what looks like a peripheral calcification. It's very well defined, and there's no other lesions anywhere else. And so this ends up being it has to be, so is it extraaxial, intraaxial? And so one of the things you can do is try and see if you can look and find any sort of CSF fluid around it. And I feel as though that actually there is a little bit of CSF fluid around it on the CT scan anyway. An MRI scan would be easier to confirm. But on this particular view, you can almost see a bit of CSF going around that way and around that way. So something that's a lobulated lesion located within the ventricle and has got the CSF sign would be in keeping with a large meningioma. And so you've got meninges inside the lateral ventricles, and they can have meningiomas just like any other part of the brain. Just I haven't really seen one like that before, and I think it did stump a few people in the beginning. Okay, so let's have a look at this case. So this looks like an X-ray of the knee, and they put a question mark on it. Questions? No. Zoom it a bit. Okay, so I wouldn't be too worried about this. You can get a bit of calcification in the interosseous membrane area, so that's fairly normal. That's the lateral and medial tibial spines. You've got your medial tibial plateau here. You've got your medial femoral condyle. You've got your lateral femoral condyle. They all look okay. You should really be able to see the patella shadow, and I think it's probably somewhere over here. Can't see any calcifications or calcifications here, and this would be where the MCL would be. So sometimes you get calcification along there, but we don't have that. And the tibial spines look okay as well. So let's zoom in a bit. So that's the fibular head going like this, all the way around, all the way around. But actually, there's what looks like there could be a bit of an abnormality here. Looks very like there's a bit of a flake of bone coming off the lateral aspect. So that this is going to be a second lesion. And when you've got a second lesion, you'd have to, it's almost like pathognomic or like very likely that someone's got a second lesion, they're going to have an ACL tear. So the ACL tear is all the way over here. And the theory is you get sort of capsular avulsion. So it's not the LCL. The LCL goes this way. You've got popliteus that goes around the back. You've got your biceps tendon and your iliotibial band and all the rest of it on the outside. There's none of those things. It's like the capsule of the joint. It kind of pulls as a result of the twisting and bending motion of the knee, and you get a tiny flake of bone called a second fracture. And that's what this is, and actually ended up being quite a significant ACL tear. Okay, let's have a look at the next case. Just trying to make sure there's no questions coming in. I can't see any questions coming in now, so let's zoom in. So this is an elbow. And in truth, when I look at elbows, I just go straight for the radial head. It just would be most of the time the most likely cause for any abnormalities on the elbow, especially in a trauma case. So let's just use that idea. So let's zoom in, zoom in, zoom in, and just have a look and just see if I can draw around it. So I feel like I can draw around, I can draw around, I can draw around like this. And then the neck looks like it's pretty good, like this. But there does seem to be, so if I draw around like this, a bit of a discrepancy there. I feel like the discrepancy goes all the way along like this, like that. You draw around like that, that looks okay. And just look at the rest of the bones, just try and see what the articular surfaces look like, get an idea about what the rest of the bones look like. And it just seems a bit odd that that little square, if I was just to draw a square like this, that one area looks kind of weird, doesn't look quite right. Let's have a look and just have a look at the rest of the arm. They look like they've got one of those IUD things in their arm. I can't remember what they're called. So yeah, when you zoom into that, that is pretty convincing that there is actually a radial head fracture on this one with articular surface involvement. So quite important you say that. Radial head fracture with articular surface involvement, no impaction, no dislocation, no bony fragments. This just looks like an impact fracture. The most likely, they fell on their arm and the impaction ended up going into the arm, went into the radial head and ended up getting fractured. Very, very common. So if you're not looking anywhere, look at that place first, and then that would be the quickest way to get the diagnosis of most elbows if there is an abnormality in the first place. Oh, this looks difficult. Okay, let's have a look at this one. Hmm. Okay, so we've got to go back to basics. Got to try, if we don't see it straight away, we've got to try and go back to basics. And so one of the basic things I always taught everyone is to have a look at the lung apices, right? And so you zoom into lung apices like so. Oops. Pattern across and try and draw a square like this, like this. And if you need to use your hand, draw a square, and see if there's a difference. So one other way is like if I get you to look at that square, look inside that square, close your eyes, and open your eyes, and now look at this other square. And actually, you'll see, yeah, there's a difference between the two, isn't it? This looks like there's lung markings going all the way to the edges, and this one doesn't look like there's much in the way of lung markings at all. So if that's definitely the case, we need to try and see if we can find the edge of the lung. And the edge of the lungs, you have to remember, the lungs are like a balloon. So when it gets popped, it kind of you will see the edge of the balloon somewhere. So let's see if we can find this edge of the balloon. Difficult to see, but you can definitely see lung markings going up to here. And then you can see the rib. And just around here, you feel as though there could be another line just there, like that. And then I can't really see it beyond there. But that could very well be the edge of the lung, which is overlapped by the rib. And on the rest of it looks okay. So this looks like it's going to be a left apical pneumothorax, probably up to this level. And those things can be really, I mean, they're very, very easy to miss because, yeah, at first glance, if I did it again, at first glance from far away, might walk away from that. I think, yeah, it's fine. So that's why I think it's really important to have basic rules. So I always use this one's what I do first. Have a look at the lung apices. If everything doesn't, it looks okay, then I'd have a look at the costophrenic angles like this and like this, and that looks okay. Then I'd look at the aortic knuckle. I look at the hiatal areas. I look behind the heart to make sure there's nothing abnormal. I look at the heart itself, make sure the contours are okay. Everything looks okay. It definitely is this. And then if everything was all right after that, I'd also look at the bones. Now, one thing to say is that it's very important that when you've got a pneumothorax like this, you shouldn't just stop there. You've got to try and look and see what's caused the pneumothorax in the first place. And obviously, yeah, pneumothoraces can happen spontaneously. I get that. But you also still got to remember that, yeah, fractures can cause pneumothoraces. So you've got to try and make sure You look all the way around, all the way around, all the way around, all the way around, all the way around to make sure there's no evidence of any fractures. Have a look at the scapula as well, because sometimes that can be an indication of an injury of an acute kind. But this one looks like this may well be a spontaneous pneumothorax because I can't see any evidence of any fractures or trauma anywhere else. Oh, another sign of trauma would be just have a look at that costophrenic angle and see if it's blunted, because if you do have a traumatic injury, you may have a bit of blood or a bit of a kind of a reactive effusion to the trauma in the first place. Okay, cool. Let's have a look. No questions so far. Good. Okay, let's go to the next case. All right, look, I think this one follows onto this one, so let's have a look. So this is a chest X-ray again, and let's have a look and see what's going on. So we could do, if you weren't sure, then I'd always stick to my rule. So have a look at the lung apices, draw those squares, make sure that they are completely fine. And yeah, they're fine. Then I'd go to the costophrenic angles, make sure they're nice and sharp, which they are, which is good. And then you want to check behind the heart. That looks okay. Under the hemidiaphragm looks okay. And you also want to check the mediastinum. So it's the mediastinum here that doesn't look quite right, because you'd have an aortic knuckle, which would be like here, but this looks a bit large. So it could be an aneurysm of some sort, maybe. So it could be a big aortic arch aneurysm. But then when you look on this side, it's unusual for the aortic arch to kind of do this and come back round. It normally would do this and then go right down the middle, right? You won't normally see it from the AP view. So it feels like there's some sort of added value over here. Now, the hilar on these X-rays actually look okay. And I know that hilar can be very, very difficult, especially in the beginning. But you just, when you look at the kind of these regions here, there is a bit of a sharpness to it. There should be like V's. This one just kind of gives us feeling that there could be something behind, like posterior. The ribs don't look like they're broken, doesn't look like there's any erosions either, but it just feels like either there's going to be some sort of aneurysm, which is unlikely because on this side as well, or there's going to be some sort of soft tissue mass located within the region of the mediastinum. So soft tissue masses in the mediastinum, what could they be? Most likely they're going to be underlying lymph nodes. So lymph nodes could be the cause of this. Now, when you look at this person, they look like they're pretty young actually. You can tell from the bones, from what the bones look like, or there's any calcifications on the sort of more chondral areas of the ribs. This looks like it's okay. So therefore, this is a young person with what looks like multiple mediastinal lesions. So your differential is most likely going to be something like lymphoma, right? So it's going to be lymphoma. Infection can cause enlarged lymph nodes. Tuberculosis, sarcoidosis could cause enlarged lymph nodes. But now we're going to have to go for the CT scan. And I do have a CT scan for us to look at. So for this one, what I'm going to do is I'm going to download this. And just have a look at what's going on. So for this one, I'm just going to do scroll through first. On the very top, very, very top. So, okay, so it looks like we've got the neck. Scroll through, scroll through. What are people thinking? Scrolling through, scrolling through. Okay, fine. Let's come back to around this level. So something's up, something's not good. So what we saw earlier was that they did have what looked like quite a large aortic knuckle. So therefore that must be all of this. That corresponds to that, doesn't it? They also had what looked like a lesion coming out this side. So actually, yeah, that looks like there's quite a big lesion there as well. The hilar regions, which is what we were talking about earlier. Yeah, remember we were saying on the X-ray, they look okay. Actually, there's not much in the way any hilar lymphadenopathy here. It seems to be all sort of superior mediastinum. It's a lot of superior and actually anterior mediastinal mass as well. So anterior mediastinal mass, what else? What's the differential for that? I think it's lymph nodes, thymoma, teratoma, thyroid. Those are things that could be in the anterior mediastinum. So let's look for the thyroid gland. Where's that? I don't think I can really see much of a thyroid gland. Must be somewhere here. But it doesn't look like there's anything continuing from the neck and down. There's a bit of fat plane, and then you start getting to this large lesion. So now you're thinking, okay, it could be teratoma, it could be multiple and large lymph nodes. So now when you come to the bone windows, you can see bony destruction of the sternum, right? You can see that. So that's what normal bone looks like. Let's zoom in just to show you guys. That's a normal bone. That's a rib. Pull this across, and that's just not much in the way of bone left whatsoever. So that is not looking great for this person at the moment. So reset all. We've got broken sternum. So okay, so now we're thinking, okay, whatever this is could be an aggressive process. So it could be, we're saying lymph nodes won't be causing destruction of the sternum like that. So maybe it's not a lymph node, it could be an underlying teratoma, right? It could be something like that. And so but then the things that make you think that it may not be is all the stuff's happening everywhere else. You've got big lesions located within the axilla bilaterally. Can you see those? And then in the chest wall over here, coming further down, and there's a few lymph nodes that are enlarged in the sort of cardiophrenic angle as well. So that's not good. And so yeah, a few people coming up with some good answers, but the problem is what you have here are these lesions that are here. I mean, are they lymph nodes that are sitting with the anterior chest like that? And I've also got this sort of fluid density within it. And so as you look around, some of them have got these sort of fluid densities within them as well. So yeah, there could be necrotic lymph nodes. This is fluid density located within this region as well. So, okay, let's just keep that all in mind and let's have a look at one more thing. Oh no, it didn't work. Okay, we're gonna have to forget that then. Okay, so yeah, a lot of good answers. So far we've got sarcoma, thiomec, carcinoma, and TB. And so now when you look at this, this is actually a what they call a cold abscess, right? So cold abscess is, I mean, it looks like a collection, doesn't it? Sitting in there. You don't really get lymph nodes and sort of in that subcutaneous tissues over there usually. And so when you've got something like cold abscesses, you got this sternal destruction like this, then you're going to have to go down the idea of this being TB. That's exactly what it was actually. A really, really bad case of tuberculosis on this person. And then, yeah, probably one of the worst cases of destruction of the sternum itself. So, yeah, and then I think everything else is okay. The imaged upper abdominal solid organs are fine. And then the bones are all okay as well. Right. Let's have a look. Do I have any other cases? I think I might have zoomed through all those cases. There was there something that was handed over? Let me just check if I can get it. There might be like an extra one. Let me see if I can find it quickly. Won't take a second. Okay, here we go. Yeah, found some. Let's have a look. I haven't seen this one yet, so copy link. Hopefully it works. Case 13, what was the diagnosis? Case 13? TB, tuberculosis. Okay, let's do this one. I haven't seen this case, so I'm going to learn with you guys once it downloads. The hotel internet's been pretty good so far. By the way, if anyone comes to Dubai, you should definitely check out a particular restaurant called Cheap Meals because I've invested in that in Dubai Creek. Random plug. It's very good. Best burgers in Dubai. Of course, I'd say that. Right. Anyway, what on earth is going on here? Okay, so it looks like we've got a CT scan. Just waiting for this to come across. Sorry, guys. Won't take too much longer. Really weird jumpy thing. I might just try and reload it and just download them all. So we've got a non-contrast and we've got a Porta-Venus phase. I just noticed that. Okay, fine. So why would we do that? So non-contrast and Porta-Venus. So I guess we're worried about bleeding somewhere. That might be what it is. He's jumping around that one. Let's go for this one, see what happens. Do one scroll through, one scroll through, one scroll through. Oh, so fecally loaded. So you can see all this stuff sitting within the bowel. It looks so I've seen the cheat meals and socials. It is good. Thank you for seeing that. Okay, let's have a look. So scrolling, 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 scrolling. God, you know what? I don't know what's going on this one. Just so much feces everywhere. Quite unusual. Scroll, scroll, scroll. Transverse colon. Lots of feces still, lots of feces everywhere. Okay, so yeah, I don't know why it's kind of stuck right now, but I haven't seen anything grossly abnormal on this one just yet. Just loads of fecal loading. Don't know the age of the patient. They do have what looks like a bit of endometrial thickening, but maybe that's just appropriate for the age because they look like they could be fairly young. Um, and then let's come back up to the top. I did see a cyst just there, liver. So let's look at the gallbladder. Really squashed up there, isn't it? And the kidneys. That's another cause of problems. Kidneys. Hang on, what happened there? So this one. Kidneys look okay, don't they? Right. What are the clinical details here? Material and gas shut off. Material gas shut off. Diffuse, a distension diffuse occlusion. I can't understand what that says. I mean, to me, when I've looked at this, it just looks like there's loads of fecal loading, like all over the place. Really, really bunged up. But when you actually look at the bowel, I haven't seen anything grossly abnormal with the actual bowel wall. I haven't seen any twisting of the bowel either. Um, and they're saying, let's have a look. You say sigmoid colon, so come up this way. Sigmoid colon, come up this way, come up this way. It's here. That might be it. Ah, okay. See if I can get a coronal view. Sometimes that's useful, isn't it, to get the coronal view on that. So rectum coming up this way. Oh, it's tough, isn't it? That's sigmoid, sigmoid. That must be sigmoid still. Ah, it'd be a tough one, yeah. I mean, there could be a bit of narrowing there. I mean, that would explain the rest of the rectum, I guess, and why it's all bunged up like that, because it is very unusual to be bunged up like this. And so someone's saying that maybe, yeah, there's going to be some sort of stenosis or thickening there. Yeah, I mean, it's entirely possible. Direct visualization would be fairly easy with a sigmoidoscopy, and you'd be able to get to the answer to what's going on and why that's like that. At the time, at this point in time, it doesn't look like it's particularly inflamed, and they don't look like they're particularly old, from what I could see on the bones anyway. So I'd be surprised if it was an underlying malignancy at this age. I mean, it could be a focal stenosis because of ulcerative colitis. It could be a few things, but Interesting case. I mean, I don't think I would have seen it straight away personally. I would have just probably gone down the road of there being fecal loading that's causing the big issue. But no perforation, no collection, no ischemia. I guess those are the main things as well. Okay, cool. I'm going to stop there because it's very late where I am right now in Dubai. I'm just going to say thank you so much as always. I think we've gone through some fairly interesting cases. I've learned a few things today. And yeah, I guess I'll see you guys on the next one. I hope everyone has a great month. All right then. Bye.
Thank you, Imran, and thank you for joining from all the way in Dubai. I'm just sending a feedback form for everyone to complete. Once you've completed this, you'll get a CPT certificate for today's session, and we will be back next month. I believe the date it will be. Let me just double check. On the 25th of February. So yeah, please do sign up for the next webinar, and I'll see you all then. Thank you.